Alright, ethical issues in heart failure and shock, advanced care, or palliative care. Doctors and patients should have in-depth conversations about the progression of heart failure and the unpredictable length of life early on in order to plan for the future. They should also include the patient's goals and family in the process. Potential benefits and complications of intervention should be talked about and considered before moving forward with any treatment. Could the quality of life improve or worsen? ICD, LVAD, and IV therapies. ICD stands for implantable cardioverter defibrillator. ICDs treat lethal arrhythmias by shocking or pacing the heart back into a life-sustaining rhythm. These do not improve cardiac function or heart failure symptoms. VAD stands for ventricular assisted device. VADs are mechanical pumps that support failing hearts. At one time they were used for patients awaiting heart transplants. Now they can be used without a time limit for weak hearts. VADs can sometimes improve cardiac function for non-candidates, which eventually land them on the waiting list for a heart. IV inotropic agents, most commonly used at home is milrinone. It helps a weakened heart pump better. It dilates all the blood vessels in the body. So when the heart pumps, it doesn't have much resistance to pump against, and it's given in low continuous doses. Palliative care is basically just treating the symptoms. Palliative care usually comes later on in the course of illness. It just depends on the patient, and if advanced therapies would do more harm than good. This kind of care is directed towards treating the current symptoms of the patient and changed based on patient's needs. Impact of heart failure, individual and family. With all illnesses, it's stressful on the patient and family members. The individual with the disease can lose independence and require little to constant assistance from others. The family roles change. If the patient was the head of the house or main provider for the family, they may not be able to continue to work and provide for their family. Money can get tight and they may have to downsize in all areas of life. The patient who's not the main provider, but maybe the stay-at-home parent, the one who takes care of home and more of the children. The significant other would have to balance a job in addition to all the responsibilities that aren't included and become caregiver. Kids may not be able to participate in all activities because one parent is busy taking care of the other. These shifts and roles can cause a lot of mental distress and all are not able to cope. There are signs of caregiver stress to look for and know when to get help. The best caregiver can't always be the significant other or family. Everyone isn't fit for the demanding role. The earlier that this is discovered, there can be help and it can alleviate anxiety for all parties. Social life. Their social life will suffer for the whole family. The patient with the illness will be more fatigued and little exertion can be difficult to manage. Their lifestyle will change drastically. Women in childbearing age would be cautioned against becoming pregnant. It will worsen the disease process and may be fatal for mom and the baby. Jogging, walks, any kind of exercise may be non-existent for the individual. Going out with friends may seem more like a burden. Some will become withdrawn and isolate themselves. The best thing to do would include them even in little ways and help that individual stay positive. They would need to develop more hobbies and stay as active as possible. Some of the cost. Treatment for heart failure is readily available. The treatment differs from each individual and course of disease. Costs can be anywhere from tens of thousands and upward. Insurance does cover majority of the cost. The individual will be responsible for some. Over the course of the disease, there will be many doctor's visits, most likely dozens of hospital stays, many PO medications, possibly IV home drugs, and implantable devices. The support groups can be found for individuals and caregivers. Some groups are online and they are easily accessible. They can discuss daily issues that arise anonymously. There are also heart failure clinics that offer support groups so the individual can openly discuss successes and setbacks in dealing with the illness.
Okay, now that we've talked about heart failure and gave you some history on heart failure, and we've done the patho, side effects, and a lot more different things about heart failure, now we're going to show you all how to do a care plan and how to take care of a patient with heart failure. First, we got a problem list. The problem list has the top 10 problems that could arise from heart failure, and they start with number 1, potential for decreased cardiac output. At risk for cardiogenic shock is number 2. Potential for elevated blood pressure, potential for altered respiratory status. Number 5 says potential for impaired circulatory function. At risk for social isolation is number 6. Number 7 is risk for declining activities of daily living. 8, risk for fall with or without injury. 9, potential for fluctuation in weight. And 10, potential for maladjustment and health changes. We're going to do a care plan on the top 5. And this is just to help you all come up with a plan of care for patients with different problems that has heart failure. This first one is really a slide that I did, and I highlighted some stuff so I can point some things out, so you won't see the highlight on all the care plans. But the first one is potential for decreased cardiac output related to heart failure. That is our problem. Our care plans must have a problem, a goal, and intervention. The problem is potential for decreased cardiac output related to heart failure. The goal. We have to make sure our goals are set so that they can be reached. We don't want to set goals that are not reachable goals. And each patient's condition determines what that goal will be. So this patient goal, we're going to put patient with not exhibit signs of decreased cardiac output through 10, 12, 16, which gives them 3 months to show whether our plan of care is effective for them. Interventions. Right here on the interventions, I do have number 1 listed as a baseline EKG, chest x-ray, BMP is ordered. And what I have highlighted is for you all to see which discipline will be responsible for helping monitor this, or which discipline will be responsible for actually performing this task. So right here on the lab, I put licensed nurse. Make sure that this is done so that we can make sure this intervention is in place for this patient. Second one is cardiac diet is ordered. That's the dietitian. We need to get the dietitian involved anytime we got a heart failure patient so that we can monitor their sodium, make sure that they're getting the diet that they need. Third is complete vital signs every shift. This is where I included the CNAs and the licensed nurses again, because we need to make sure CNAs are aware of what the blood pressures and vital signs should be in patients with heart failure. Medication review by pharmacists every month and as needed. Pharmacies are always important to make sure that we got them on the proper medication that's going to be effective for them, and make sure that they're not on any drugs that's going to interact with each other that will cause harm to the patient. We will notify the physician as needed for onset symptoms. I put licensed nurses this. That's so that licensed nurse can know that we need to notify their doctor anytime we have any change in condition or onset symptoms for this patient, so we can try to head them off before they get too bad. Observe extremities for edema report is indicated, licensed nurse. And you get the picture from there. You can kind of go down and read what each intervention I put in place for this patient with decreased cardiac output. And it also shows each discipline that I use during this on this particular care plan. The next is at risk for cardiogenic shock related to pulmonary edema and heart failure. Patient will not have any signs of cardiogenic shock through 10, 12, 16. Once again, that's our goal, and I did a 3-month goal to make sure that we are meeting, we're having short-term goals and we're not doing anything that we cannot meet. If you look at the interventions, you will see all of the interventions that we put in place. On this particular care plan, we got Dick Johnson. And if you would look down, some of the care plans will have some of the same information as the others because sometimes they overlap. But this is a care plan that I did come up with for a patient that has cardiogenic shock. Next care plan is potential for elevated blood pressure related to smoking, heart failure, obesity, coronary heart disease. Once again, patient will maintain the blood pressure within the following parameters, which are listed. And I also set a goal, the patient will remain free of complications related to hypertension through 10, 12. Once again, you can look at these interventions, and you can also see each discipline that I use in order to monitor for the effectiveness of the intervention. Next care plan is problem for altered respiratory status related to difficulty breathing, pulmonary edema, and decreased cardiac output. Once again, as you can see, we have a problem, we have a goal. Goal date is for 3 months out, so we can have short-term goals to see if we're meeting them. And we also have the interventions listed with each discipline that will be responsible. But as you can see on this one, I do have respiratory therapy involved on this care plan, so they can help us with this patient's altered respiratory status. And respiratory therapists will be responsible for incentive spirometer or anything that has to do with the respiratory system. The next care plan is potential for impaired circulatory function related to heart failure, diabetes, and renal insufficiency. Once again, goal is only a short-term goal. We're going to do it through 10-12. And once again, we have all the interventions listed with the disciplines that will be involved with the interventions. On the care plans,